Hi, good afternoon. My name is Christine Luyo. I'm a midwife at Jacaranda Maternity, and today I'll be your friendly guest to talk about the topic that was communicated earlier on gestational diabetes. We have several questions that were earlier sent, and as we continue sending in questions about gestational diabetes, you want to understand more about gestational diabetes. Before I jump straight to the questions, maybe we can first go back and understand what diabetes is in general, for us to be able to understand what gestational diabetes is. You'll find that the blood usually has sugar levels, and for you to be able to control your sugar levels in the blood, there's a hormone called insulin that converts the excessive sugar in your blood to other components. I won't go deeper into the details. So when we talk about diabetes is a condition where patients cannot properly control their sugar levels in the blood. That might occur in two different ways. One, it might be because your body or you are not producing, or the pancreas is not producing enough insulin to control the sugar levels in your blood. Most of the time, that one we call it type 1 diabetes, and you can be born with that condition. We also have another type of diabetes whereby we call it type 2 diabetes. Yes, you might be having enough insulin. Remember, the first type 1 diabetes was that your body is not able to produce enough insulin. Type 2 is whereby you have good insulin, your body is producing enough insulin, but your body is resistant to that insulin that has been produced. So the cells are not responding well to that insulin, making you have more blood sugar levels in your blood. That one we call it type 2 diabetes. So the question comes in where, what is gestational diabetes then? I have type 1 diabetes, I might have type 2 diabetes. So what is gestational diabetes? So when you look at pregnancy in general, pregnancy is a state that is at a risk on its own way. And pregnancy complicates this more, whereby at times you might have good sugar levels, good control of your blood sugar levels before you got pregnant. But later in pregnancy, someone tells you you have diabetes and you've never had a history of diabetes. This is because pregnancy complicates the situation by making the insulin that you have either resistant. That's where now the blood glucose goes high. And that is what we call gestational diabetes. The question that you'll get is, can I get gestational diabetes if primarily I never had diabetes? In my history, we never had diabetes. The answer is yes. I'm asking this because you'll find that a client comes, or myself, I come to you, I'm pregnant, and then I'm being told to do a test to find out or to assess if I have gestational diabetes. But I'm very resistant because according to me, we don't have that history, so I'm very resistant that I don't have gestational diabetes. For me to be able to take that test, I'll have to understand how it comes about. Sawa. So the thing is, you'll find that if you don't have any risk factors, when I talk about risk factors, I talk about several things. Maybe you have a history of gestational diabetes. Maybe this is your third pregnancy, and your previous pregnancies you've been getting big babies, or you have a history that you had a stillbirth. Or let me say in layman's language, ukikuwa karibu kujifungua, mtoto wangu nilijifungua kama amefariki. But you don't really know why you had a stillbirth. Another thing is you are obese, or you have a BMI that we usually take mostly when you come to your first clinics. It's more than 30. Obese, we call it obese. That's a risk factor. Or you have a history of shoulder dystocia. Wale watoto wakati wa kujifungua wanakwama, nasikia kichwa ilitoka and then akakwama, we call it shoulder dystocia. That's also a risk factor for you to get gestational diabetes. Or in your previous pregnancy, you were told that your sugar levels were very high. It's a risk factor of getting gestational diabetes. For me, let's say I never had a risk of gestational diabetes. I come to the facility and I'm being told about diabetes in pregnancy. So we usually want to do a test called OGTT between 24 and 28 weeks. But the question will be like, why is it that in pregnancy I can get GDM or gestational diabetes? This is because of the placenta. If you go through many complications of pregnancy, you'll find that the placenta mostly is usually the problem. So in pregnancy, we usually from 20 weeks and above, it usually produces some hormones. These hormones in your system make your body cells resistant to the insulin that you have. So remember we talked about type 2 diabetes. If your body cells is resistant, meaning the excessive sugar in your blood levels will not be converted to other components that we talked about. Therefore, you'll be having high levels of blood sugar in your blood. So let me jump to the first questions that I have as we wait for other questions to come in. So how will gestational diabetes affect my pregnancy and my baby's health? Let me start with the maternal side. When you have gestational diabetes, you are at risk of getting high blood pressure or preeclampsia. I don't want to go in that line of preeclampsia because we're talking about GDM, but you are at risk of getting other conditions that affect pregnancy and are riskier to use. We call it preeclampsia. This is because it affects the placenta. The high levels of sugar in your blood will affect the placenta. And if your placenta is affected, it triggers your blood pressure to go high. So you'll be having many complications like what we call placenta abruptio, preterm labor. The mother also, you'll find that, because at times for GDM clients will be advised on diet. You'll be told to go and see a nutritionist to be able to be guided on what kind of foods to take on or how many proportions or so that you can also control the way your body is responding to the excessive sugar in your blood. Mothers who have gestational diabetes in pregnancy might, I'm using the word might because it's not necessary, it's not a must that you'll get diabetes type 2. Remember I started with types of diabetes. Diabetes type 2 later in life. This means that your body cells will continue having that resistance to the insulin that is supposed to control your blood sugar levels. What about the baby? You get mothers with very big babies, so that's a chance of that baby also having trauma during delivery. Remember, if it's normal delivery, that is a baby also who will be at risk of maybe, let's say, dying intrauterine or having an IUFD or a stillbirth before your due date. This is because the excessive sugar usually has an impact on the oxygen supply to the baby. So by the time you continue with your advancement of your pregnancy, the excessive sugar in your bloodstream will have a hindrance of oxygen supply to the baby. Na pole mtoto wako anaanza kuchoka, and then you have an IUFD. What else can happen to the baby? We talked about trauma, a big baby because of trauma. Then also later, after delivery, what usually happens to the baby? Remember, this baby has been in a medium of very high sugar levels in your blood. So the baby produces its own insulin. The insulin is like a positive feedback. If I have very high levels of blood sugar in my bloodstream, what happens? I will produce more insulin. Remember, the insulin produced by the baby is acting in regards to the maternal blood glucose. Immediately the baby is born, the baby's excessive insulin will convert the sugar levels in its blood. Therefore, it will make the baby have less sugar levels. We call it hypoglycemia. You'll find that these kind of babies usually end up in nursery care, NBU, for checking on their blood sugar or how they are controlling their blood sugar levels. And this is where at times you'll find that a mother, I had my baby, I delivered my baby, I slept, and then later on askia, my baby died while sleeping, but we never know why your baby died while sleeping. Then when you go back to look at the history, you'll find maybe you had gestational diabetes. This is because when the baby was delivered, without your knowledge that you had gestational diabetes, the excessive insulin in the baby converted the sugar levels in the blood until the baby got hypoglycemia, low sugar levels in the blood. When you have hypoglycemia, this baby will not be able to cry, this baby will not be able to move, and that's how they die while sleeping. So that's why it's very, very dangerous. It's also traumatic to the mother during delivery, because at times, if you get shoulder dystocia, it's trauma to the mother. You are at risk of getting those tears, bad tears, because it's a big baby. Another thing is like you are at risk of also having a cesarean section as compared to normal delivery. This is because for those mothers, when you talk about management later, for those mothers who are diabetic, we don't usually allow them to go up to term. So they'll come in for an induction of labor earlier enough. Yes, spontaneous labor is usually the best, but for early induction of labor also increases the chances of you for going for failure in induction. So you'll be at a higher rate of going in for a cesarean section. Yeah. So the next question was, what dietary changes do I need to make, or do I need to manage gestational diabetes? Before I answer this question, I'll go back to how will you tell that you have gestational diabetes? So when you come to our facility, let's say it's your first clinic, you're around 10 weeks pregnant or 12 weeks pregnant before your second trimester. What we usually do, we screen you. Screening is not only lab test, but it also comprises history taking. We'll take your history. From the history taking, if I find out that you had a history of gestational diabetes or a big baby, or that history runs in your family, I'll think about doing an OGTT. For our first time clients who come here, we call it profile tests. It comprises so many tests. We usually also do an RBS, random blood sugar levels. If that time I find that your random blood sugar levels is high, we usually categorize it in levels. I can recommend that you come maybe the following day to do a test called oral glucose test. And then we proceed from there. If you have no risk at all, we'll just do the normal random blood sugar to have a baseline. And then there's a test that is usually done between 24 and 28 weeks. Remember I said gestational diabetes is mostly due to the placental hormones that are usually produced, and its peak is between 24 to 28 weeks. So that is the time we do an oral glucose test. You'll come in the morning. I'm sure those who have been with us throughout the journey, they've heard about it. Then you'll be given glucose. A tumbler that has been glucose, 75 grams of glucose for you to take. Before you take that glucose, we'll first want to know how is your blood glucose level. So they'll first do a test. You take that glucose, drink, and remember you'll have been told to fast for 8 to 12 hours, because when we book for your OGTT during your next clinic, you come, you're given what to do before you come for that test. And so what happens if after you take that glucose mixture, we'll give you 1 hour. We want to see how your body cells react to that excessive glucose. After 1 hour, we'll do a test, the random blood glucose level test. Then we also wait for another one. So after 2 hours, so if you, from the time you took that solution up to the second hour, we'll also do another test. So we've done 2 tests. And then from those results that we'll get, we matched to the control blood glucose levels to tell us if you have gestational diabetes or not. So I know the question is on diet. So there are those clients who will be managed with diet because their levels are not too high. There are those clients who will be managed with oral medication, zile dawa tu za kumeza, and there are those clients who will need insulin injections. So all of them are usually managed differently, and their timing for delivery is also usually different, and also the risk factors varies. So any client who comes in and is noted to have gestational diabetes is usually directed to also see a nutritionist for review. Clients are different, demands are different, so we see each and every individual being different. So when you have a talk with your nutritionist, she will be able to have a meal plan for you. And we usually say, if you look at the pregnancy state itself, it's a state that requires a lot of energy. I know some time back we were being told when you're pregnant you're eating for 2 people, but that's not the concept. We usually tell you just eat a healthy diet. You're not eating for 2 people. So eat a healthy diet, and if you have gestational diabetes, that doesn't mean that don't eat carbohydrates, don't know. When you start doing that, you'll find that yourself not taking a very balanced diet. So you'll find that you'll be told to take balanced diet, snacks in small portions, but frequent meals. Take a snack, avoid junk food, avoid very sweetened beverages. So when it comes to diet, you'll be guided to a nutritionist who will take you through your journey. The next question was, how often do I need to monitor my blood sugar levels? Looking at myself, I've done that OGTT, and then I'm being told, now for you need a diet control gestational diabetes. You will not need medication, but we'll still have a follow-up with you. As Jacaranda Maternity, we have a coordinator who coordinates this. At times, I know it's very shocking to be told you have diabetes and you've never heard about it, and that's where at times denial comes in. But we also have to understand the risks that it comes with. So the coordinator will be able to tell you how frequent you'll be testing your blood sugar levels. A maximum of 3 times will do. You'll be told to take a fasting blood sugar, that is in the morning, very early in the morning when you've not taken anything. And then after lunch, 1 hour later, you'll take another test. Then after dinner, 1 hour later, you'll take another test. So you'll be shared the contact of our coordinator. When you do these tests, you'll be able to send the results to her, whereby she'll be able to advise you on the way forward if they are within the normal ranges, if you want you to come back. So what will I use to test my blood sugar levels? I can't be going to maybe my lab area 3 times a day. It's a bit tedious. So what we've done as Jacaranda Maternity, we give you a glucometer. You pay 2,500, which is either redeemable on delivery or refundable. It's not that you're buying the glucometer, it's just that the 2,500, you'll use it later or it will be refunded when your journey has completed. So we want you to be able to do your own test, which you'll be trained and you'll be shown, so that you will be able to send the results to our coordinator later. If you're using medication, if you're on diet, you'll be told to come for your follow-ups after every month, provided you're sending in your results and we are able to monitor your progress while at home. If you're on medication, or let's say your sugar levels are not well controlled, you'll be told to come in after every 2 weeks for assessment. What are the risks associated with gestational diabetes, and how can they be minimized? As I mentioned earlier, we categorize them between maternal risks and neonatal risks, and we also talked about stillbirth, trauma during delivery, risk of you having a high chance of going in for a cesarean section, induction of labor to you and the mother, also a risk of developing developing type 2 diabetes later in life. To the baby can also develop diabetes within the first year of life to 10 years of life. And if I look at this baby, remember, if they develop diabetes, We don't have oral medication for babies under 10 years. So this is a baby who will be put on insulin. This is a baby, and you know, insulin is very, very expensive. So this is a baby also who will not be able to participate in sports activity very well because of exertion, and we don't want the sugar levels to go very down. And also gestational diabetes has a risk of babies born with renal problem, the kidneys are not functioning well, cardiac problems, we have a problem with the heart, and also the brain problems. The excessive sugar in the blood has an effect on the development of all these three things, and also other systems that I've mentioned, but mostly you'll find it usually starts with the cardiac problem, which is at a high risk of developing. Then the neuro, that is the brain, and then the kidneys. The other systems like the muscles comes later. So how can they be minimized? They can only be minimized by, you have to be screened if you have gestational diabetes. That's why it's very, very, very important to do oral glucose tolerance test. That is what we call OGTT, between 24 and 28 weeks. For those with risk factors, you'll find that you'll do OGTT several times. If you have a very high risk chance of getting gestational diabetes, I'll do it during your first visit, or I'll plan earlier in pregnancy. At 16 weeks, I'll also plan to do gestational OGTT, oral glucose tolerance test, if the first one was negative. And then at between 24 and 28 weeks, we'll also do an oral glucose tolerance test. That one is only for those who have a very high risk of getting gestational diabetes, or you have a history of gestational diabetes in previous pregnancies. For any other client who does not have any risks, we just do it between 24 and 28 weeks. The question is, what if I miss my OGTT test between 24 and 28 weeks? We really, really encourage you to do the test between that period. But at times, things just happen. It was missed, or you came when it was very late and you had no option of, you were not given that option of doing OGTT. We will do other tests. You can decide to do a random blood sugar level test and a fasting blood sugar level test. But the best indicator is usually OGTT. But since you've missed that window period, it doesn't mean that we will not be able to do something. We will do it, but remember the sensitivity also matters. The next question is, will I need to take medication to manage my gestational diabetes? The answer is yes or no, depending on the results that we will get after your OGTT tests. As I said, there are those that will just manage their gestational diabetes with diet and frequent testing to know if they're within the normal ranges. There are those who will be started on medication, we call it metformin medication immediately. And also depending on how you are managing your sugar level controls, you will be given a dosage according to how the sugar levels in your blood are behaving. And there are those ones who will need insulin. Those are the injectables that we give for very high sugar levels that are not responding to diet or oral medications that we give. So another thing is, can gestational diabetes affect future pregnancies or increase my risk of developing type 2 diabetes later in life? I think I had answered that earlier. Can gestational diabetes affect my future pregnancies? Yes. Remember, we said any history of gestational diabetes will also affect your future pregnancy, because we will be at a higher risk of getting gestational diabetes. A risk doesn't mean you'll get it, but you'll be screened and precautions put in place, so it can affect your future pregnancies, and it can also increase your risk of getting type 2 diabetes later in life. Let's say you have gestational diabetes, you've come to deliver. After delivery, you'll find that after delivery, if you had gestational diabetes, it can stop immediately. You won't have gestational diabetes. And that's when you are being told that we can stop your medication if you are on medication immediately after delivery. So, and if another person will be like, what if I am told to continue my medication? You'll be told to continue medication if Because what we usually do, we usually monitor your sugar levels after delivery. If we still see that your sugar levels are still high after delivery, our gynecologist will advise you on what to do. You'll continue taking your medication, but when you come back for review, we'll also continue testing and seeing if it has subsided, because most of them usually stop having diabetes immediately after delivery. And then at 6 weeks, it's very advisable for you to also come and do the same OGTT at 6 weeks, so that to know if you're not at risk of getting type 2 diabetes mellitus, the one that we said it's insulin resistance. So, and that is the time we also do further tests, like if you come at 6 weeks and the OGTT is positive, we'll think about doing other tests, endocrinology tests, such like HbA1c, which will be guided to rule out any risk of developing type 2 later in life. How often should I see my healthcare provider for checkups and monitoring? As we said, those who are on diet will just continue coming in recommended after every 4 weeks, because yes, you have gestational diabetes, but your sugar levels are well controlled with diet. Those who are on medication, you'll find that we will really need you to come after every 2 weeks for assessment. And apart from just coming in, you'll find that you'll be doing more ultrasounds. Because remember, we said the excessive sugar levels in your blood has an effect on your baby's growth, has an effect also on oxygen supply to your baby. So we'll do a growth scan at 28 weeks. Remember, we usually do, if you have no risk factor, usually do an approximate of 3 scans. But if you have any other risk factors in pregnancy, we do more scans, because there's a dating scan, there's an anomaly scan that we do around 20 weeks. And then at 36 weeks, we do another scan. For those who are on medication with gestational diabetes, you'll find that we'll do another scan at 28 weeks, a growth scan. After 4 weeks, another scan at 32 weeks, and another scan at 36 weeks. We'll look at different parameters. How is the flow, oxygen, Dopplers, how is the oxygen flow, blood supply to the baby. Apart from the scans, you'll find that from 32 weeks, you'll also be doing a sensitivity test for your baby. We usually do a CTG called a CTG. When you come in, you'll be advised on what is a CTG. So we just want to know how the baby is doing in your uterine. So you'll find that you'll do at 32 weeks, you'll do a CTG. Then when you get at 36 weeks, you'll be like doing twice weekly CTG, because we want to know, is this baby coping well with the high sugar levels in your blood system? Is this baby growth restricted? Is this baby able to continue with the pregnancy, or we need to deliver this baby earlier? That's why we said earlier on that you have a very high risk of IUFD. If we don't do this, we can miss it. You'll come back and you say that my baby is not moving well, only to find that maybe the baby died earlier on because of things that we could have prevented. So will my baby need special care or monitoring after birth due to gestational diabetes? Let me just complete the whole question. How can I manage my blood sugar levels during labor and delivery? So the first question, as we said earlier, remember your baby while in utero was receiving blood from the mother. Blood that had high elevated sugar levels, right? The baby produces its own insulin. So the insulin produced by the baby is responding to the high levels of sugar levels, meaning the baby has a very high level of insulin. When the baby is born, the baby is now not receiving blood from the mother, the blood that had high levels of glucose. So the excessive insulin the baby will be having at that point will convert the minimal glucose level in the baby's bloodstream, therefore going into hypoglycemia. So when your baby is born, this baby will need more observation, more monitoring, and also NBU care to be able to know if this baby is able to control its own blood sugar levels until they are standardized or until they are within the normal ranges. That's when now we can discharge the baby and continue with normal newborn care. And remember, I also talked about those babies who die while sleeping. It's the same concept. And that mostly happens for those mothers who have not been screened. They think their baby is very okay. You have a baby who is 4.3 kgs, you've never been screened of gestational diabetes, you go to sleep, you breastfed very well, and later on you find your baby is not moving, very lethargic, or dies while sleeping. That's just because the baby had hypoglycemia that was not picked early during pregnancy. How do I manage my sugar levels during labor and delivery? If you are on diet, we continue with diet. And our nutrition department, our dietary department are usually made aware. So when they are serving meals, they usually have a special meal for the diabetic clients that fits within their recommended plan, diet plan. Those on medications will also continue getting their medications to control their sugars, and you'll find that we'll be frequently monitoring your sugar levels. Will gestational diabetes affect my ability to breastfeed? No, it will not affect your ability to breastfeed, and we will continue encouraging and preaching the word of breastfeeding within the first 1 hour, breastfeed until completion of the 6 months, and breastfeed until the baby is 2 years and above. So it won't affect your ability to breastfeed. What signs or symptoms should I watch for that might indicate a problem related to gestational diabetes? As we said earlier, gestational diabetes mostly is due to insulin resistance because of the hormones produced by the placenta, and the peak is between 24 to 28 weeks. For diabetes, you'll find that you urinate frequently, but remember, with pregnancy that still happens. You sweat a lot, thirst, hunger. So those are the signs and symptoms, but we don't wait for the signs and symptoms. We screen early to avoid maybe later problems. How can I cope with the emotional stress of managing gestational diabetes during pregnancy? This is a good question, because you'll find that most clients will, don't want to call run away and go elsewhere, or come later when they are due to their pregnancy, or when they've seen a danger sign, because we talk about danger signs in pregnancy, because there was that aspect of denial. No, I cannot be having diabetes. No, my family does not have diabetes. And the moment you do that OGTT test and you're told, ma'am, your sugar levels are high, so you'll need to start medication, you freak out. You start being depressed, you start being stressed. Then you're like, no, my grandmother never did this test. My grandmother delivered with no any medications when it comes to diabetes. So that denial is there, we understand, but the only thing that can be able to help us cope with the stress or cope with the depression that comes with it, it's just understanding why it happens, accepting that it is there, and also doing what is recommended to avoid complications to the mother and also to the baby. Remember, we also said it has an effect to the baby's development of other systems like the cardiac, brain, and also the renal function of the baby. Are there any long-term effects of gestational diabetes that I should be aware of myself or my baby? We said you can develop gestational diabetes later in life. You can develop diabetes type 2 later in life, and your baby can also develop diabetes. And if we have any neuro problems and we have any cardiac issues that developed intrauterine due to the high sugar levels in your bloodstream, yes, they can be long-term. So it's good to be screened. Na tusiogope. This is something that we can't control. This is something, the placenta is there. The placenta supplies the baby with nutrients, so it has to be there. Yes. And other women also, other clients will also develop, as we said earlier, pressure, pregnancy-induced hypertension, and this can also continue after delivery. So another question is, will my baby be at risk for developing diabetes later in life due to my gestational diabetes? Yes, I think I've answered that. And we said it's usually, if I get my baby, maybe my baby is 4 years now and has developed diabetes in life, that baby will be on insulin. Those are injectables, and which are very, very expensive for the family, which will also cause stress to you and also the baby. How can I prepare for a healthy postpartum period following gestational diabetes? For this one, I'll still continue insisting on nutritional counseling, keen clinic follow-ups. You'll find that for high-risk mothers, we'll really advise them to come for their follow-ups after between 7 to 10 days the first time. They'll still come for their follow-ups at 4 weeks, and also at 6 weeks. It is very important when you bring your baby for the clinics or for the vaccinations, you also see the gynecologist, because remember we said you can develop it, but it's not a must. So a healthy postpartum period is just following the recommended guidelines that have been shared with you, the health messages, and let us be positive. Let us be positive, understand why we have it, and not live in denial. This also goes during your antenatal journey, because the moment I have denial that I have gestational diabetes, I end up not taking medications, I end up not doing the tests that are being recommended to be able to monitor your sugar levels. Are there any specific precautions I should take in future pregnancies if I had gestational diabetes before? I would advise for preconception counseling. If you are planning to get pregnant, come. And also, don't shy away when you are sharing your history. That is a very significant element to remember. Remember, in my previous pregnancy, I had gestational diabetes. It was a complicated delivery. And also for those ones who never had gestational diabetes, histories like when I was talking about risk factors. The last pregnancy, I was told I had shoulder dystocia. Shoulder dystocia, we've said, it's a risk factor for gestational diabetes. Shoulder dystocia doesn't mean that your baby has to be 5 kgs, that your baby has to be 4 kgs. A baby who is 2.5 kgs can still get shoulder dystocia. This is because with the high sugar levels, find that the fat deposited at the shoulder or at your baby's shoulder is the one that is causing the shoulder to stick maybe during delivery. So if you had a history of shoulder dystocia, if you had a history of gestational diabetes, if you had a history of stillbirth or an unexplained losses, please share that information so that your screening can also start early. Can gestational diabetes increase the risk of complications during labor and delivery? And if so, how can the risks be minimized? As we said, yes, it can increase the risk. That is to the mother and also to the baby. We talked about trauma. We talked about shoulder dystocia. We talked about if the baby is big at times during normal delivery, it's a bit tricky, so you end up in for cesarean section. And these are the mothers who will also come in early and not on their due date for delivery, and mostly you'll find that you'll be induced. And if you're induced early, we have failed induction. So another question is, what can I do to balance my fasting sugar? I think here we are talking about the fasting blood sugar that we usually do very early in the morning when you've not taken any food. I've not understood the questions very well. Maybe you can rephrase it, because there's nothing that you can do to balance your fasting blood sugar. If you want to know your fasting blood sugar, make sure you've not eaten anything for approximately 8 hours. And it usually has a range. It's not only one value, it has a range that we use. How high is high? So that's a question that, so I think it's on the fasting. So it's up. If I have a fasting of more than 5.3 levels, that is high. But how high is high? The same way as I talked, you can have a high blood sugar levels that is just managed by diet, so it's not very high. You can have a high sugar level that is just managed by medication, that is metformin or very high for insulin. For that one, that's why when you come for your OGTT tests, it's usually combined with a gynecologist review. You'll come and the levels are there. So using your results, your 2-hour results, they use it with the recommended values. If it's high, now that's when you'll be guided if you'll start diet, if you'll start on medication or insulin. So advice on a diet for someone with gestational diabetes, as I said, but I'll still touch on it, that people are different, have different calorie intakes, so we don't generalize. So you have a talk with your nutritionist whereby you'll be guided. But what we usually say, avoid junk food, avoid beverages, sweet beverages. Then I will not tell you not to take carbohydrates. I'm sure maybe outside there someone will tell you don't take carbohydrates. No, we don't say that. We tell you to take meals in small portions, but make sure they are very balanced and a lot of fruits and vegetables. If my spouse is diabetic, does it have effects during conception? The answer is no. Remember, we usually say risk and history of diabetes in your family line. And also if you yourself has a history of having gestational diabetes or the risk factors that we've talked about. Yes. As we wait for other questions, the question is, if I'm on diet, at what point will I be told to come in for induction of labor? Or at what point will I be told to deliver? Because you'll find that I'm at 40 plus 2 days and I've not delivered, I'm at home. For those on gestational diabetes controlled with diet, we usually just monitor your sugar levels on controlled diet, and you can deliver when your labor comes spontaneously, or come for induction at 40 plus 6 days, just like any other pregnant lady. For those ones who are on metformin or on medication, that is oral medication, they'll be told to come in for induction. We don't want them to go past 39 weeks. So if you are at 38 plus 6 weeks and you've not gone into labor, you'll be told to come in for induction of labor. For those who are using insulin, you'll be advised to come in for induction of labor if you've not gone into spontaneous labor between 37 weeks and 37 plus 6. So on insulin, we don't want you to go beyond 38 weeks. On oral medication like metformin, we don't want you to go past 39 weeks. Or gestational diabetes with diet control, with keen monitoring of your blood sugar levels, if they're okay, you can deliver as the rest of the population. Yes. Thank you, Dan. Any other question, maybe?
Yes, one other question.
Okay. So, the last question maybe, as we wait for others. So the question is, what is the normal range of a normal OGTT test? As I said, after 2 hours, when you come with your fasting, usually say for fasting blood sugar, it should not go beyond 5.3, 5.4. If it's above 5.4, you'll not be given the glucose to take. So that's why we start with the fasting blood sugar. For after the 2-hour test, we don't also want you to go above 7.8. The random blood sugar should not be above 7.8. Yes, if I get a random blood sugar of more than 10 after the 2-hour OGTT test, That is someone who start on medication immediately and not just diet. Around 8 to 9, I might give you a diet. You can be given like a 1 week to assess yourself, to do your sugar level tests, to know where we lie, and to know if you'll just continue with diet control or on medication. So immediately the OGTT, immediately the 2-hour OGTT is more than 10, you'll be started on metformin immediately. Yes. So is the test to GDM important when starting ANCs? As I said earlier, we really thought that this topic is, it was a good topic, because if we don't understand the importance of doing the OGTT test, that's when we shy away. If we go back to history, kitambo hatuko tunafanya OGTT test. This is because, but it's a recommendation of WHO and also the Ministry of Health. And if you also look back on the history of the stillbirths that we are getting and complications, and also the researches that were done, so we were losing so many mothers and so many babies just because we were missing that element of gestational diabetes. And for you to be able to screen it, the OGTT is the best marker when you're pregnant between 24 to 28 weeks. So the question is the test to GDM important when starting ANCs? When starting, it will be important if you have a risk factor, like you have a previous history of GDM, you have a previous, your babies, you've been having big babies, or you have history of pregnancy losses or stillbirths. That is a client that when you start your clinic, will also think of doing an OGTT test early in pregnancy. And also if it turns negative, you'll find that we'll also want to check again at 16 weeks. If it is still negative, we'll also want to check between 24 and 28 weeks. So yes, with the risk factors and complications that come with GDM, it is very, very important to do that test. So does water help in reducing blood sugar level tests? This is a good question, kwa sababu mimi ukinipatia sukari nyingi nikiweka maji, I dilute it. Juice with a lot of sugar, if I put in water, I dilute it. But here we have to also understand the concept behind how our blood sugar levels is converted with the insulin. So when you look at your liver usually produces sugar to your bloodstream. And this excessive sugar is supposed to be converted back. So insulin does that for us if we don't have any resistance. If we have normal insulin, it does that. What pregnancy does, it when those placental hormones are being produced by the placenta, it creates a resistance to that insulin. When it creates a resistance to that insulin, we are not able to convert the excessive sugar levels in our blood back. So taking a lot of water is good for rehydration. It's very advised during your antenatal journey, but it has no effect on the blood sugar levels. And that's why when you're told to come for your OGTT test in the morning, I remember usually told to come very early in the morning, and your last meal should be around 9 p.m. Usikunywe chai asubuhi, because if you take tea in the morning, when you come back, you will be rescheduled. No vigorous activities at night, and that's why unambiwanga avoid sex that night. Sawa. But you can, if you feel you need to take something, you can only take a glass of water. So it has no effect. So will taking the Ozical meds in the morning before the test affect OGTT results? No, it won't. Those are calcium supplements, it won't. So thank you so much. It was a pleasure. And I hope we won't shy away. We can also do more research on GDM and its effect and the importance of having it. And if you are told you have GDM, let us be positive and let us follow the recommended management. It doesn't mean that since I have GDM, I'm the weaker person here, or since I have GDM and my sister did not have it, I have a problem. No, it is just the placental hormones that have created that resistance to the insulin. Sawa.